about cancer inequality with a focus on breast and cervical cancer. So first, we have inequality across country in Europe and in the world. You see on the left the probability to develop cancer for breast and cervix and the probability to die from cancer for breast and cervix. And if we have, and we know we have higher incidence of breast cancer at the west of Europe because we know that breast cancer is a disease of westernization, and is one of the main risk factors is to have children late and to have less children, so it's higher in more developed countries. We see that the mortality is different because, in fact, once you have cancer, you have breast cancer, your chance to die from it is much higher in Eastern Europe. For cervical cancer, it's the same, but here the incidence is quite similar to the mortality. The chance to develop cervical cancer and the chance to die from cervical cancer is higher at the east of Europe. I don't know. Okay. There is a bad... yes. So this was about inequalities across country, but we have also inequality within countries, specifically for cervical cancer. It's known since quite a while, and this is a study from 2003 from our friends at International Agency for Research on Cancer. Low socioeconomic status is increase the risk of developed cancer, and the more you have socioeconomic inequality in a country, the more the difference. So 50% in Western Europe, 130% in North America, and 200... yeah. There is a bad contact, I think. Thank you. Why this? We know that low socioeconomic status is associated with the typical risk factor of cervical cancer, like vaccine hesitancy, tobacco consumption, earlier and multiple pregnancy, which is actually a factor that protects from breast cancer, so you have a balance. And also lower access to screening and to treatment. And here is the result of a study from my friend Salvatore Vaccarella at IARC, showing the mortality by cervical cancer in some EU country according to level of education. And you see that the black dots are lower, the lower third in terms of education, and the white dot the higher third. And you see that if across the EU, women of high education have kind of similar mortality by cervical cancer, it becomes really different when it goes to women with lower education. And in this eastern country, Poland, Lithuania, Estonia, you have level of mortality for women with low education, which are similar to the mean mortality in Africa. And here there is a difference of 8 times, here 6 or 7 times. So you see really a big difference in terms of mortality for people with low socioeconomic status. For breast cancer, it should, in fact, everybody should be like Italy, which actually do quite well when it comes to inequalities according to socioeconomic status, because we know that women with higher education are more at risk of breast cancer, because they did study, they did not do children when they were 20. So this should be the same. This should be the same across country, but we see that in fact once you have breast cancer, your chance to die from it is higher if you have low education. And one of the reasons for this is the difference in stage, and here this is the result of a study in France. The late stage diagnosis between high socioeconomic status and low socioeconomic status, a difference of 15%. So women of low socioeconomic status are diagnosed of their breast cancer later than women with high socioeconomic status. And it's not only due to lower screening, it's also due to the fact that the health system, when they have a symptom, when they have lump, is not serving them as well as women with high socioeconomic status. Sorry, that was a little mistake. So what to do against all these inequalities? At WHO, we have a recommendation along the whole cancer control continuum, so for prevention, early detection, diagnosis, treatment, and supportive care, palliative care, and rehabilitation. And for example, when it comes to prevention, what all our guidance are really evidence-based and free from any conflict of interest. And for example, when you go to prevention, one important factor for cervical cancer, alcohol is an important risk factor for breast cancer. We have studies what works and what doesn't work, and typically, the media campaign, the health literacy don't do a lot, while activities such as increasing tax, reducing availability of the place where the alcohol or the tobacco is sold, reducing the time where it's sold. So, for example, Finland recently closed all the alcohol shops during the whole weekend, and the alcohol consumption has really decreased in the country. So these things that work, and what is their cost effectiveness is in our documentation. We have also a guide to screening, but also early diagnosis of symptomatic cancer, which is so important. And so this kind of information all along the continuum. We have also specific guidance for cervical cancer. I will just speak about this one on breast cancer, which was issued 2 weeks ago, about patient navigation for early detection, diagnosis, and treatment of breast cancer. On average, a woman who have breast cancer see more than 30 health specialists during the first year of her breast cancer. So navigation is really something that makes a difference, especially for women with low education, because it's difficult navigation to go through these steps. So we provide information for rich and poor country. And when we go in country and advise according to evidence, we see usually we propose when we propose an evidence-based action to a country, it will save money. So you think that Ministry of Health will pick them up, but we realize that not so much, and that while we have like no-brainer solution for in some case. There is a big barrier which makes that the policy recommended and the policy that makes sense are not picked up in countries, and this major barrier are the commercial determinants of health. So what are the commercial determinants of health? The definition is that it's the private sector activity that affect the health of population, positively or negatively. So negatively in the case of alcohol, tobacco, so it's all the activities the industry of tobacco, alcohol, processed food and chemicals can do against a policy that protect health. But when you speak about early detection, diagnosis, treatment and palliative care, you have also to put in the mix the pharmaceutical and medical device industry, which do a lot of positive things, of course, to tackle cancer, but also some negative things, and it's appear more and more clearly. And also, there are medical service providers subject to financial intensive. And for example, when you speak about screening, it can be like, the professional society can be problematic. For example, in Germany, the urologists may make something around 50% of their revenue thanks to PSA screening. So for them, it's also a source of revenue. So we have begun to study that, realizing that cancer is a frequent disease, so it's a big market. In fact, 1 European out of 3 will develop cancer in their lifetime, so this is 2.7 million new cancer per year, new cancer patient per year. There is also, the screening is also a huge market, because if you add all the people who should be screened, you get something like 400 million people in the EU. And we, realizing that this could be a problem, we asked 3 years ago to eminent experts to study the case along the whole cancer control continuum, which ended up in the special issue of Euro Health, a journal for Ministry of Health with 8 articles about the commercial determinant, prevention, screening, pharmaceutical and non-pharmaceutical technology, and even palliative care. And it was quite eye-opening, and since we have begun to work on that, we were quite shocked. So the article about prevention was interesting because it gives a typology of industry tactics, the 3F and the 3D. What industries like tobacco, alcohol, processed food, and some other industry are using. Fear of bad impact on economy and employment, an argument which is used a lot with policymakers. They fund politicians, they fund front group, real NGO, or they even create fake grassroots NGOs and fund them to provide their message. The denialism decreased the impact on health risk, what the tobacco did at the beginning, but not anymore. But they also fund alternative research, creating multiple expert opinions. For example, research showing that vaping can help you to stop tobacco. Deflection is focusing the prevention dialogue on consumer responsibility and not on the responsibility of the industry. It's also something we see for screening. So this is an important issue in prevention, which is recognized since a long time. But the more we study it, the more we see also similar behavior from the pharmaceutical industry, from people in the pharmaceutical industry. But we have now evidence, researchers who are studying commercial determinants, and it's really a science. It's, like biologists who decide to study a little corner of a field to understand the different interaction between the plants, the insect, and so on. Here, you look at the economics of health and try to understand the interaction. And these researchers have found that companies influence all the ecosystem from research. Oops, sorry. There was something wrong with this. From research to market authorization to clinical guidelines and the prescription practice of the doctors. We made a report in 2019 at WHO showing clearly some of these aspects, and also the fact that companies disburse more on marketing and promotion of their medication than the research and development. We know there is low bar for medical device to be put on the market, but we see a decreasing one for cancer drug, and this is problematic. Another issue, due to the fact that pharmaceutical companies have gained little by little the power to dictate the price they want, is that oncologists have now are faced with very expensive drug. And if at the end of the 90s, the median monthly cost of a new cancer drug was below $2,000, today, it is around $20,000 to $25,000 for a monthly treatment. So it's out of my year. We are 2010. It was 10,000, but today it's 20,000 to 25,000. So we have really a problem with the cost of medicine, and the Ministry of Health are calling to WHO. The Western EU Ministry of Health, like Norway or Holland, are calling to WHO to say this is not sustainable anymore. And indeed, if you look over the last decade, from 2005 to 2018 in the EU, the cancer incidence has increased by 25%. But the cancer drug costs have increased by 220%, while the overall cost was increasing also, but the other cancer cost was increased by 4%. So the more you pay on the drugs, the less you pay on other things like, human resource, beds, and length of stay in hospitals. Another problem is that since you can sell so expensively the latest drug, the companies have all interest to sell this latest drug preferentially to the old one, which were cheaper. And that's a problem because it decreased the bar of the quality, as I said. We have here the review of all the drugs approved by the European Medicine Agency since 1995. This is one of the studies, but there are some others which all show the same, which is that there are a lot of new drugs who are not better or even worse than the previous drugs which were cheaper. And so, of course, we have still some new drugs which are super excellent and save a lot of life. But this problem, these drugs are more a problem everywhere, and even more in low and middle income countries, because they are more vulnerable to pharmaceutical promotion. There is less regulation. And we did recently a study of the drug reimbursed in a Caucasian country and found that 19% of the drug budget was spent on these negative benefit drugs, and 20%, so up to almost 40% of their drug budget could be spent better. So it means that in countries like that, the patients really don't get the best they could from what is reimbursed by the states. And in the EU, the problem is also there, but not as important, of course. Screening is also is usually not in the debate, but it's very influenced by commercial determinants. We see more and more pharmaceutical companies and medical device companies promoting aggressively screening, and of course, specifically screening test, machine. There is direct-to-consumer test. There is, ask your doctor for this or this, if you should not be screened for this or that. They use methods like used in by pharmaceutical company, ghostwriter, publication bias, funding of NGO and patient association to relay their message. They have really succeeded in focusing at the EU level the early detection conversation on screening, ignoring early diagnosis of symptomatic case, which is really important because when you think about breast cancer, you think about screening. But in fact, in Denmark, the country where I live, where more than 80% of women are screened by mammography, it's only 35% of all breast cancer which are found by mammography. Screening is not so efficient at finding all the cancer. And there is really a very important role for early diagnosis of symptomatic case. And in Denmark, at the end of the day, where all screening programs have participation above 80%, only 8% of all cancer are found thanks to screening. So why the early diagnosis of symptomatic case is not part of the conversation or even not part of the EU Beating Cancer Plan, it's an open question. What we see more and more in EU, but also out of EU, is opportunistic screening, which we know doesn't work very well. Especially to tackle inequalities. And we saw that in Estonia and Lithuania, we had high level of cervical cancer also because in this country, there is still opportunistic screening for cervical cancer. We see more and more non-evidence-based screening. For example, thyroid cancer screening is a problem in the north of Italy and the south of France. While it has really no benefit and only harms. We see a lot of push for cancer screening at early age, which, somebody who don't know screening very well would say, yeah, it's better. Well, actually, it has a lot of harms too. Screening can harm, so it has to be very highly quality assured. So this practice increase also as a result of commercial determinants. So what are the solutions here? What I do today to raise awareness, and we try to do that more and more among doctors for them to better resist pharmaceutical promotion. Of course, among governments and EU officials, these are our primary targets. We ask for stricter regulatory standards. We want also, in general, more transparency from the commercial sector about the benefits and harms, about the research and development cost of medicine, which is usually used as an argument to explain why the medications are so expensive. But again, our report from 2019 debugged this argument. And we ask for better protection from influence. So I will finish. Just give you here the link to 2 reports. So the one I told you about, but also a newer one about commercial determinant in non-communicable disease in general, where you will find a lot of stories and examples. It's really easy to read one. And thank you very much.
Thank you very much.